sweating or dryness of skin, no history of postural giddiness. No history of involuntary movements, no history of stoop posture or diminished arm swinging, no history of speech or memory disturbances, no history of LOC or behavioral or emotional disturbance, no history of sleep disturbances, no history of delusion or hallucinations, no history of seizures as well. No history of headache, fever, vomiting, neck stiffness, no history of loss of weight or loss of appetite, no history of weight gain, constipation, dry skin, no history of abdominal pain or loose stools, no history of bone pain, cough, breathlessness. There is no history of chest pain, palpitations, or syncope. So coming to the past history, there is
and she says that she already has some problem. She had a febrile illness for about 3 days. Can you get that? So just a few things. At the onset of a problem, she had a febrile illness for 3 days. She had body aches and all that, but then passed, and then after that, this started. And the second thing she told me is that in the last 2-3 months, she has noticed this red spots in the legs and the back, and they're itchy, but they don't fade off. I mean, they fade off after some time and they become dark. Okay, leaves behind pigmented scars. And the third thing that is a little different is that the giddiness was there in the beginning. She was given some Cinnarizine, and then after that, she doesn't feel dizzy anymore. So these are some additional things that you may have to take into consideration.
sure.
I have a general comment on your presentation. Instead of saying no history 100 times, say what he can do. For example, if you say no history of difficulty, why don't you say he is able to swallow food normally, instead of saying no history of difficulty in swallowing? It's all right, you can say it a few times, but this is many times. So presentation sounds better if you say it positively rather than by negative.
Sure.
Yeah, and they can, all the negative things, like Dr. Payne is saying, if you make it a little less elaborate, then whoever is examining you remains interested in your presentation. Otherwise, they tend to switch off. There are too many negatives, right?
Let us understand. Let's finish the history, then we will
Past.
start. Past.
Coming to the past history, she does not have any similar complaints in the past. There is no history suggestive of chronic illness, like TB, malignancy, HIV, or syphilis. No history of diabetes, hypertension, chronic kidney disease, or dysthyroid state. Treatment history.
Just one second. She had a fall and a head injury when she was very young. She told you that? Okay. I think maybe worth mentioning it. Don't leave it out. It may have no relevance to this, but she did have a fall and a head injury. And she gets episodes of vomiting. Did she tell you that? She gets bouts of vomiting. What she does is she goes on a fast every now and then, several days in a year. And whenever she fasts, she tends to vomit. These are two additional things that she mentions. There's a history of weight gain of 4 kgs in the last 8-9 months. She'll gain about 4 kgs. And she says that she has a problem that she's very sleepy all the time, and she feels very cold. These are the additional things that I got from my conversation with her.
Coming to the family history, in a 3-generation pedigree chart, with the siblings of 2 sisters, she is the only one affected in the family of 3 generations. She has one daughter who does not have, one son who does not have any complaints so far. So,
Coming into the family history, her mother's brother has a psychiatric illness.
intellectual disability.
Is that right? Yeah, okay. Yeah, we got that put down there somewhere. We do not know whether it's a neuropsychiatric illness or just a psychiatric illness, but there is an illness in one of the brothers pertaining to the central nervous system, mother's brother.
So, summarizing history, 35-year-old middle-aged lady presented with swaying while walking, with smearing of food, swaying towards the side and backwards, suggestive of appendicular, truncal and gait ataxia. The possibility of cerebellum and its connections are considered.
Okay, straight away you're saying, when you just summarize the case, put it in a way that which is the level of, which is the level you can explain together. And then you talk also about the possibilities of what is the etiology. Where is the lesion? In any neurological case, those two questions must be answered. Where in the neuroaxis is the lesion? And two, what is the lesion? So you have touched upon straight away saying, because he has got an ataxia, history of incoordination, so it is probably it is. But then summarizing has to be a concurrently looking at why it is not something else. Okay, you have put a whole lot of negative, you have thrown away all that. So how do you come to that? What are the causes? I would have said this presentation would have said because of 1, 2, 3. Everything put together, it could occur in the cerebellum. Why it is not altered, a loss of coordination could, or a loss of balance could occur from other sites as well, isn't it? So why is it not other sites? And then what is the lesion? That's how you should summarize it.
I agree. I think when you summarize this kind of a problem, imbalance, you need to say that there's nothing to suggest peripheral neuropathy in her on the basis of the history. There's no involvement of cranial nerves, higher intellectual functions were normal. And there's no motor deficit in terms of loss of muscle power. So in the absence of all this, you would consider cerebellum as a locational lesion. Then again, you can refine it a little bit more. Is it a central vermis lesion, or is it a cerebellar lobe lesion, or does it have to do with cerebellar connections?
So she.
Why is it not the ear? The balance gap.
So for cerebellum localization, she has difficulty in holding the tumbler and smearing of face. So that contributes to the cerebellar hemisphere. She also has difficulty in walking with the gait imbalance that contributes to the central vermis.
Vermis lesions, what are the unique features? What are the unique features of lesions involving the cerebellar vermis?
Gait ataxia, truncal ataxia.
Gait or
Truncal ataxia.
truncal ataxia? Does she have truncal ataxia?
When she was sitting, she was swaying back and was not able to sit without support in the history.
She is able to sit in bed, right?
Currently, she said improvement is
She
there.
is able to walk, even though it's a broad-based case. Now, people with truncal ataxia would find it very difficult to do that. So she doesn't seem to have vermis lesion. You think it's both lobes of cerebellum or bilateral?
Yes, sir.
Okay, bilateral and more or less symmetric.
More or less symmetrical.
More or less symmetric. Okay. You said the lower limbs were involved first.
Yes, sir.
And then the upper limbs got involved. Is that correct? What does that mean to you? In short, what is the representation of the body in the cerebellum? Is it upside down, or if you have got a lower limb problem first, and then ataxia involving the incoordination involving the upper limbs, where do you think the problem started?
Peripheries are usually in the cerebellar hemisphere, and the central part is in the upside down in the anterior cerebellar lobe.
So if the lower limbs were involved, which part of the cerebellum?
Hemisphere.
The anterior and superior part of the cerebellum probably got involved first, right? That's the conclusion you would draw from that. Fine.
Regarding the etiology, onset and progression of the disease is very important to interpret progression of the etiology, isn't it? So is it a vascular? Is it a infective? Is it a neoplastic? So you have to have some comment on that.
Sir, vascular unlikely because it's not sudden in onset, it's gradually progressive insidious onset. Demyelinating post-infectious is a possibility because she's had worsening and then had an improvement that has been static. And tumor wise, she's got a symmetrical presentation. Usually it will be asymmetrical presentations.
Sudden onset and there has been some improvement.
Yes,
so you think demyelination is likely.
Yes.
You think vascular is unlikely because
Incidence onset and
vascular
gradual.
also sudden onset.
It usually will not be progressive. So it's just a
that-
maximum at presentation, they will have a maximum deficit.
So there was some progression.
Yes, sir, she had.
Okay, fine. But there has been improvement also, right? Okay. But which vascular lesion can involve both lateral lobes of the cerebellum simultaneously? Anatomically possible? Both cerebellar hemispheres to be involved at the same time. Which blood vessel? Anatomically, is it possible? Can you locate it to a single blood vessel? If you can't, that is a point against this being a vascular lesion. Okay. So, go on.
So from your, can you re-summarize what you said? Where is the lesion and what is the lesion?
Yes, sir. So summarizing, a 35-year-old middle-aged lady presented with swaying, smearing of food, swaying towards the back with no involvement of motor system or sensory weakness, no autonomic or higher mental function involvement. This actually points to the cerebellar hemisphere as well as the mostly anterior lobe of the cerebellum.
Any past treatment? There have been 8 months. Was she given any treatment?
She mentioned only this Strugeron, that is the only tablet she was given. Otherwise, she did
For the
maintain.
giddiness and that went off. So
Very
she did not receive any
Any other
treatment so
treatment.
far. Okay, fine. So in the absence of any treatment, there has been improvement.
Mm.
Okay.
Ask this question. What are the etiological things that comes to your mind when somebody comes with an acute cerebellar syndrome?
So acute cerebellar syndrome, it could be vascular infection as well as drug related. So vascular, it will be usually infarct or hemorrhage. So infection, post-infectious cerebellitis or abscess, they can present with the acute cerebellar ataxia. Drug related phenytoin toxicity, lithium toxicity can present with this barbiturate poisoning.
Can febrile illnesses produce cerebellar syndrome? Just fever, high fever.
Yes, it's possible.
You give an example. Any common infection that's often followed by a cerebellar syndrome?
Varicella and influenza.
Pardon?
Varicella and influenza.
Chickenpox? Yeah. I think that's probably the most common thing that you would see in clinical practice. Chickenpox, small percentage of people will develop a transient cerebellar syndrome, right? Okay.
Okay. So going on to the examination, general examination, patient is moderately built and nourished. She's conscious and oriented. There is no pallor, icterus, cyanosis.
Can I again interrupt you? See, when you present your general examination findings, please mention all the positive findings first. And then club all the negative findings together and say no. Okay. That has a greater impact on people who are listening, right? So what are the positive findings on general examination?
She had some hyperpigmentation in the bilateral lower limbs, or otherwise nothing I could. In the bilateral lower limbs.
The legs.
Legs.
Are there any reddish lesions? She has some of them over the back. Okay. So she has skin lesions. I think that is an important physical finding that needs to be highlighted. The lesions that you see over the legs are scars, pigmented scars, but over the back she has got 1 or 2 reddish spots. And she says whenever they come, they're itchy, but they don't fade off. So what kind of disease causes itchy red skin lesion that leaves behind a pigmented scar? Vasculitis.
Yes.
So which particular vasculitis causes an itchy red lesion? What about henoch-Schwann-Lyon perfusion? Okay, that's the most common. It's a leukoangioclastic vasculitis, which leaves behind pigmented scars, and it's red and itchy, it doesn't fade. Okay, but other forms of vasculitis as well. Not her history is not like the henoch-Schwann-Lyon, but she has these lesions in the skin, which I think you should not miss.
Sure, sir. Coming to the vitals, her BP was 170 millimeter of mercury measured in the right arm in supine position. Pulse rate was 80 per minute, which was regular. Temperature was 98 Fahrenheit. Respiratory rate was 18, and height tract ratio was 13:6.1, sir. So coming to the central nervous system examination. So higher function, she's conscious oriented. Memory is immediate, recent, and remote memory is normal. Speech is normal, and cranial nerves. Second pupils are bilateral, 3 millimeter reactive to light and accommodation. Fields are normal. Visual acuity normal. One does no optic atrophy or retinitis pigmentosa.
Say that when you present it, there's no retinitis pigmentosa. What conditions produce it?
Spinocerebellar atrophy with 7.
Anything else? No,
Okay.
there are a whole lot of.
Kearns-Sayre syndrome.
No, not 1 or 2. There are 7, 8 conditions which produce retinitis pigmentosa. When you say negatively saying no retinitis pigmentosa, make sure that you know at least a few conditions upfront. Okay.
And then third, fourth, sixth cranial nerve examination, extraocular movements were normal. She had a slow saccades, which was noted. Pursuit was normal, and she had a torsional nystagmus was present. Fifth, seventh.
And its thing is that physical finding, torsional nystagmus.
On looking onto both the sides, she's having this torsional nystagmus.
That's when she is looking straight ahead.
So to the left, right, lateral side, she's able
The
to.
left side.
Lateral as well as.
Okay. Yeah. Okay, fine. I'll check that later. Is there a special significance attached to torsional nystagmus? Is that of localizing value?
Yes, sir. Cerebellum. Usually, cerebellum usually can have upbeat vertical as well as torsional nystagmus. If torsional nystagmus is present, it usually localizes to cerebellums.
Yeah. I thought when the lateral lobe of the cerebellum is involved, the nystagmus is usually horizontal. Is that correct? So there is a disparity between what you got in the history and your physical findings. So I have to be very careful about that. Okay.
So peripheral nystagmus, central nystagmus, they can have horizontal upbeat as well as torsional nystagmus. Peripheral, they can have torsional nystagmus, and fatigability will be present in peripheral nystagmus. It will be absent in the central nystagmus. There will be associated deficits in the central nystagmus, and in the peripheral nystagmus, they can have tinnitus, ear discharge, and infection. In the peripheral nystagmus, is usually sudden in onset. In the cerebellum, it's gradually and progressive in nature. The treatment with the flunarizin is usually helpful, whereas in the central cause, it usually not helpful. She did not have any other cranial nerve deficits. So coming to the motor system examination, so coming to the bulk, in all the bilateral arm, forearm, thigh, and leg, she had almost equal. There was no differential wasting in the noted. Tone was normal in all 4 limbs. Power in the neck, flexion, extension, it was 5/5. Shoulder, abduction, adduction, flexion, extension was 5/5. Elbow, wrist, hand grip is also 5/5, and the hand grip is also good. In the lower limb examination also, hips, flexion, extension, abduction and adduction, the powers are all 5/5. Knee also, ankle, dorsiflexion, plantar flexion, power is 5/5. External hallucinal longus muscle power is also good. She did not have any involuntary movements. So reflexes, superficial abdominal reflexes present in all 4 quadrants. So deep tendon reflexes, biceps, triceps, supinator, knee and ankle, she had 2+. Plantar reflexes was bilaterally flexor.
Expect in a jerk, in a cerebellar.
Pendular knee jerk.
Did you check it?
Yes.
But you didn't write it.
The cerebellum I read. No, sir. More than 3, it should, more than 3 to 1 from moment, it should be there to call it as a pendular region.
What happens?
So they can have it.
Can have hyperexia or If the reflexes are brisk in a patient who has cerebellar disease, what do you consider?
Associated pyramidal.
That takes about 5 years. Okay, fine. But if you did find any,
Yes, sir.
not a low effect.
Yes, sir. So coming to the cerebellar examination, she had a torsional nystagmus.
Dysmetria. Can you
Yes.
explain that?
Yes, sir. So when the patient is asked to grab an object, there will be the patient will have actually the overshooting or the undershooting of the hands while
Is that
grabbing.
how it is defined? Dysmetria. How is it defined? It's otherwise called decomposition of movement, isn't it? That is, they are not able to judge the speed, the range of movement required to perform the task in a well-coordinated manner. So the movement is decomposed into its individual components. Okay, that's what you mean by dysmetria. Right?
She also had a scanned piece on examination, finger nose test done, which was positive bilaterally, more on the left side compared to the right side. Dysterokinesia was present bilaterally. Heel shin test, she was able to do bilaterally, did not have any abnormality.
Saying that the heel knee test is normal.
Yes, sir, normal.
Which component is normal? Placement of the heel over the knee or dragging the heel over the shin?
Placement as well as the dragging over the heel, it was normal. So she was
You
able
make
to.
her raise the leg fully up and then
Mhm.
keep it on the knee. That is abnormal. Okay, so that's where you will find the tremor. Okay, so ask the patient to lift the heel high up and then place it on the knee. That's
Okay.
when you'll find the incoordination.
Okay.
They may be able to drag it along the shin. That becomes abnormal when the problem is severe.
Okay.
Because I can't, there is an inconsistency. She is not able to walk properly. And you're saying she has got a normal heel knee test. Okay, that doesn't gel. Okay.
Sure. She does not have any rebound phenomenon or no pendular knee jerk. On rhombus examination, she is swaying to the both side left more than the right. Tandem walking, she is not able to do.
So how do you interpret her Romberg sign? So I thought that was positive usually in people who have peripheral neuropathy. Or is it
Peripheral
also
neuropathy, they usually fall, sir. In cerebellum, there will be only swaying. So in peripheral neuropathy, proprioception, they will not be able to feel. So they will not feel the position of the limb. So they'll usually fall because of it.
She is unsteady even with eyes open, right? When she keeps her feet together. Okay. So when she keeps her feet together, she is unsteady, right? And on eye closure, it becomes a little more. But people who have a positive Romberg test, they usually are able to maintain balance with the feet together when the eyes are open. Okay. So you're not able to do that. So I would not interpret it as a positive Romberg's test.
Okay, sir. Coming to the gait, she has a wide-based gait. Other examination, no meningeal signs. Skull and spine was normal. Other system examination, her thyroid and breast examination was normal. Respiratory system examination, she does not have any kyphoscoliosis. Bilateral air entry was equal. Cardiovascular system examination, apex beat is in the left fifth intercostal space at midclavicular line. First orthozone and second orthozone normally heard in all areas and there were no murmurs. Abdominal examination, she did not have any organomegaly, no mass welter, no free fluid present. So summarizing, 37-year-old middle-aged lady with insidious onset and gradually.
Walking one day, she was walking one day and suddenly felt imbalance. Is that a history? Then the onset is not insidious. Correct? It's a sudden onset problem, right?
Sudden onset and gradually progressive gait difficulty with the incoordinates of the upper limb as well, and with torsional nystagmus, with ataxic dysarthria without involvement of higher mental function, cranial nerves, motor system, sensor system, and autonomic involvement. So anatomical structures involved with the examination, I will localize to cerebellum.
Okay. When it comes to anatomical structures involved, just saying cerebellum it might be a little better to say which part of the cerebellum is involved. Yeah, looks like the two lateral lobes. Looks like the problem started in the anterior or superior part of the cerebellum and then later involved the lower part because the upper limbs got involved later, right?
Coming
So what is the diagnosis?
So you mentioned the anatomical diagnosis. Pathologically, what do you think? What is the nature of the problem? You said vascular, demyelination, infective.
Yes.
So which one would you vote for?
degenerative or metabolic.
Pardon?
Degenerative or metabolic, sir.
Degenerative. Degenerative won't have a sudden onset. Okay. The onset is sudden and that is clear. Then you have to think of either vascular or
infection.
demyelinating. Vascular is unlikely because a single vessel doesn't supply the anatomical regions concerned, right? So it's likely to be demyelinating, right? The improvement that occurred, that again is in keeping with a demyelinating problem. Okay? So if you look at it from that point of view, you will have to say it is a demyelinating problem, right? So you're putting degenerative disease like spinocerebellar ataxia first.
I think that may not.
Yeah.
I would say the first diagnosis should be a post-infection.
Demyelination.
Post-infectious because she had a febrile illness for 3 days. So it could be post-infectious. Other things that can cause demyelination suddenly is exposure to some antigen. She have a vaccine or anything recently? You didn't mention that in the history. Vaccination history you didn't mention. It's relevant. And yeah.
Historically, if she has history which says that after the first episode, there has been some separate episodes, what is the other possibility?
Multiple sclerosis.
That is, she had an acute illness, got better, got it again, got better. Is that
Multiple
kind of history?
sclerosis. Multiple sclerosis.
A relapsing, remitting
Remitting.
kind of history? Or
Discrimination in time.
Time and space.
suggest what?
Multiple sclerosis.
Suggests multiple sclerosis. And cerebellar is a fairly common way in which it presents, right? You mentioned hypothyroidism. Hypothyroidism never leads to such gross, cerebellar problem. Okay? They have a very mild cerebellar problem when they have severe hypothyroidism. She doesn't have that. She has some cold intolerance. That's just out of interest. You need to, just to see how adequate your history is. I just checked with her. She says she has cold intolerance. She has gained weight, but menstrual cycles are regular. So clinically, she doesn't look hypothyroid. Okay, fine.
So essentially, your diagnosis would rest around a post-infectious demyelination or a multiple sclerosis. So what investigation would you do to separate it out?
Initially, I'll go ahead with the MRI brain. So in multiple sclerosis, there will be dissemination of these lesions. It could be in the cerebral region as well as in the spinal cord. It could be disseminated in time and space. Another thing is CSF analysis. There will be this protein will be elevated in the multiple sclerosis, which also will help it differentiate from the post-infectious demyelination syndrome.
So you do which test? What
Oligoklonal.
test would you do in her? What investigation would you do in her?
Oligoclonal.
Pardon?
MRI and CSF.
MRI and CSF, okay. And you said MRI may not show. At now it's about 8-9 months. Okay. So CSF probably. Okay. But why do you want a vitamin B12? No, just out of curiosity, the clinical presentation. Does it sound like a vitamin B12 problem and vitamin E, right? Okay. So those may not be very useful, right? Vitamin B12 can produce ataxia, but they usually have prominent sensory symptoms. And the physical findings, what are the physical findings in B12 deficiency?
Hyperpigmentation.
Pardon?
Hyperpigmentation in the knuckles.
So there is evidence of involvement of the peripheral nerves and
Posterior.
what are the tracts are involved? subacute combined degeneration.
Degeneration.
Pardon?
Pyramidal as well as posterior column.
Peripheral nerve will be involved, but other than what tracts will be involved? Why do you say combined degeneration? Corticospinal? Yes, corticospinal is involved, and the posterior columns, right? Tracts of Gall and Bladder. So they have sensory loss suggestive of involvement of the posterior column. So the typical thing is a brisk knee jerk, absent ankle jerk, and upgoing plantar. Okay, that's a classic thing that you. So the history is not like that. The findings are not like that. So even if you find a low B12 level in a, I don't think this is a neurological disorder due to B12 deficiency. All right. Okay. You want to do anti-gliadin antibody for celiac disease. Why?
Celiac disease can present with chronically progressive ataxia. Cerebellar involvement will be there, sir.
True, but her history.
No history is present.
Celiac disease, what happens to weight?
Weight loss, lose tooth.
And they have weight loss, she has been gaining weight, right? Because you're not moving around much. Okay. You want to do a GAD antibody. Why?
Paraneoplastic.
Pardon?
Paraneoplastic work.
Go on. Tell me. I think that's an important test in a GAD antibody.
GAD antibody usually present with stiff person syndrome or pan-cerebellar involvement, usually commonly seen in small cell lung carcinoma and ovarian carcinoma.
Okay, so it is a differential diagnosis for a cerebellar disorder. Okay, and it can present like this. Only thing is the onset is rather acute. Okay, that is not in keeping with that. Can you expand a little bit more on this GAD antibody? Is it positive in any other disease?
This is type 1 diabetes mellitus.
Type 1 diabetes or NADA, okay, right. Fine. So I think the important thing is CSF, right? Do you have any results on the CSF?
Thank you. Thank you for your presentation. But when you go for an exam, you must have spent more than 3 hours on evaluating this patient. You're going to get only 40 minutes and 15 minutes for your clinical examination. So practice like that. Secondly, there are only 3 things that are important in the history for any neurological case. Nature of onset, like you said, is sudden or gradual. Then progression or stationary or improving. And the third one is, what is the present state of neurological deficiency that she has? Once you get these 3 mastered, then you do not go into elaborate. The second point is, even if you are saying that no history of, group it. No history of symptoms referable to the central nervous system or higher functions or cranial nerves or motor system or sensory system, and period. Okay. And then if you want to use selective words from the sensory system, paresthesia, numbness, root pains, etc. Because if you have to go through the entire 38 symptoms of the central nervous system, it will be difficult. In my opinion, get your anatomical level done. Just go back to the 2 slides before this. No, just cerebellum. Then now, okay, no, the next slide. Anatomical structure. Why are you bringing in spinal? You have got no spinal findings. You have got no, as Dr. Seshadri mentioned, you've got no signs of peripheral neuropathy. You understand? Or of position sense, joint sense, etc. So if you want to say it is generalized cerebellar hemisphere in affectation, okay. Now, next question, I teach that there is no system called cerebellar. It is only motor system, sensory system, coordination, reflexes, okay? Because you don't classify it as cerebellar as an examination point of view, okay? Then when you look at etiologies, you have stated that it is degenerative. Okay, there are only 9 etiologies for neurological disorders. 1 is trauma, 2 is vascular, 3 is metabolic. So you are saying metabolic is also there. Okay, so it is between degenerate. So let's say trauma, metabolic, vascular, neoplastic, degenerative, developmental, inflammatory, immunological, congenital, hereditary. 10. So you are saying that it's either degenerative or you're saying it is metabolic. Agreed, metabolic can be bilateral, degenerative is bilateral. Once you have stated those two, why are you bringing paraneoplastic? Either you take it to a different one, calling it as neoplasm, but only a paraneoplastic manifestation of cerebellar. You can put it under cerebellar. Your etiology, pancerebellum, okay? And you say that it is paraneoplastic, or you say it is degenerative. Lastly, I don't know, I have not seen a vitamin E deficiency ever. Have you seen? I don't know how this has crept into. My wife also takes vitamin E capsules. Don't tell her I told you. But I don't know what you're preventing. Zinc, molybdenum. Okay, it is very difficult. Don't waste your time drawing the family tree. Unless you are trying to say it is a congenital one or a hereditary one, etc. Okay, I am thinking it may be a paraneoplastic. If you got that weight loss and you've got a lady, but throughout your examination of the breast is a mast. You have not mentioned that. That's a common occult one. Ovarian, menstrual. Finally, in our country, I'm with HIV medicine. Don't get into sexual history evaluation at the exam level. Okay, because many people will be listening. It's a very personal thing between the physician and, I mean, I'm not talking about this patient in general, okay, because you have not mentioned the status of marital status, okay. But in general, don't get into sexual history in the examination hall. Oh, thanks.
Thank you, sir.
Yeah, among the, I think trace metals, maybe mercury can produce a bit of tremor, right? Other than that, I do not know of any other association with trace metals. Mercury poisoning can cause that, but very unlikely. She's a housewife, not occupationally exposed to anything, right? Okay. And do we have the CSF results or?
The CSF results are normal. Cell counts, she has a total WBC of 1, and the protein is 43. Glucose is also normal.
And the imaging, what is
Imaging is showing some cerebellar atrophy, but apart from that, nothing significant. No feature suggestive of demyelination or.
cerebral atrophy? No
Yes, sir.
What is the prognosis for this patient? You tell something about what will you tell after examining your the time that you're diagnosed? So what do you want to tell them?
Two things.
If you're thinking of, okay, you tell your test.
So, based upon the causes, if I think it is demyelination, she could have improvement or well as static course could be there. If it is a degeneration, we could have progressive worsening of the.
You can't say, you're telling, what will you tell this patient? You cannot, as far as talking to us, you can say that. But now you are going to tell this patient.
like to doctor and private.
Okay, but essentially you cannot have a discussion like what you did here, when it conveys it to the patient. Your best diagnosis should come forward as a very strong thing, and then say, it could be also some other things like that, but that's possible. Okay, the probability is less for that, and these are the things that you would expect. And we expect it to get better over time. Okay.
And on the investigation, maybe if they have seen the skin lesion, you might have biopsy. I don't know what that. Okay. Okay.
Thank you so much, Dr. Brightlin. We'll now move on to the next case by Dr. Namrata.